Well, in lung cancer, we all know this incredibly exciting news where stimulating your immune system actually treats lung cancer. I still can't believe that works, but it does. And we know now that the drugs are approved as second line. So you get your first line doublet therapy for metastatic non-small cell lung cancer. And of course, you've been checked to make sure you don't have a mutation in ALK or EGFR, because then you would get a targeted drug. But once you fail, and you will fail your chemotherapy, because chemotherapy is never curative in metastatic non-small cell lung cancer. I mean, maybe there's a rare event, but it's rare. So then you will get an anti-PD-1 drug. There are trials ongoing to determine maybe you should give those drugs up front. Maybe you should give the drugs with chemotherapy. Again, going back to what I said before, this will be worked out. We are trying to modulate two things at once. Make the immune response stronger and make the ability to recognize the tumor better. And when we do that well on both sides of the equation, I think you'll see the survival rates go up to levels that we can't even imagine today. So investigators have given both the anti-CTLA-4 drug ipilimumab with the anti-PD-1 drug nivolumab, I'm sorry, I said that wrong, nivolumab. And what they've seen is a very significant increase in the rate of response. I don't know that we followed the patients long enough to know if the survival is going to persist, but if that curve where the people have responded stays, it's going to dramatically be different and better. 20% 10-year survival, this could be 50% 10-year survival. I'm not saying it will be, it could be. The problem with the combination, at least that's how we did it, was it was very toxic. You know, when the immune system is on, it can do a lot of not good things. Now, the good news is we know how to turn it off with prednisone and other drugs. And as long as you know that you need to address it quickly and you don't let it go too far, it's kind of like a fire. There's a little fire in the trash pail in your bathroom and you put some water on it, no big deal. If you go out for dinner and come home, you got a problem. That's sort of the analogy I always give to patients and other doctors as I teach them. You don't ignore these symptoms, you got to get right on it. We're going to work this out. It may be that you don't need to give both drugs in full doses at the same time. It may be that you give the IPI first for a couple of weeks, followed by the Nivo. I don't know that to be true, but we're studying it. And there's data and preclinical modeling suggests that will be true, and that should be less toxic. I will say that I have no doubt in my mind we will figure out how to optimally give these drugs, and it'll be differentiated based on biomarkers and other things that we will improve outcomes and reduce toxicity.